Hello and welcome to this video. My name's Kris. I'm an Australian GP, and today we're going to be talking about something extremely common but really uncommonly spoken about: miscarriage. Before we dive into the medicine and the statistics, I just wanted to cover a couple of things really quickly. Miscarriage is extremely common. 1 in 3 to 1 in 4 pregnancies will end in a miscarriage. Miscarriage is never, ever the pregnant person's fault. Miscarriage often occurs because of a genetic abnormality of the developing fetus or baby. These genetic abnormalities often occur spontaneously, and it's got nothing to do with the parents of that pregnancy. Miscarriage is devastating at any gestation. When you fall pregnant, especially in a planned pregnancy, not always, but quite commonly, your mindset shifts. Suddenly it's not just you, it's you and a new life, and the excitement and the fear and the wonder of the pregnancy itself and what comes afterwards, and you can't help but think about what your life will become. Those thoughts can come really fast, and if you miscarry, suddenly that's taken away from you. The grief that comes along a miscarriage is unlike any other. Some people are quickly and generally accepting of it. They know that there's a risk, they know they did nothing wrong, it happens, and they can carry on from it, and that's fine. And for some people, it's a really hard thing to get through. Whatever your reaction and whatever your emotions at any gestation, it's all incredibly valid. If you are currently struggling with a miscarriage, I strongly urge you to get support around you from family, friends, and your primary healthcare team, whether that be your GP or if you're already with a midwife, obstetrician. Even psychology can be really, really helpful. You should never be alone during this. So we've kind of talked about it, but what exactly is miscarriage for those who don't know? Miscarriage is the loss of a pregnancy before 20 weeks of gestation. Any loss following this is commonly called a stillbirth. As I've already alluded to, the vast majority of miscarriages are due to genetic abnormalities of the developing fetus. It is very, very, very rarely, almost never, ever, the actions or the inactions of the pregnant person that leads to miscarriage. There is no evidence that exercise, sex, certain foods, or stress lead to miscarriage. Sometimes miscarriage can be influenced by the medical status of the pregnant person, such as having uncontrolled sugars in diabetes or poorly controlled thyroid conditions. But again, as medical practitioners, we can help optimize your health pre and during pregnancy as best we can, and sometimes miscarriage still happens. All of this to say is, if you've ever had a miscarriage or you ever do, it's never your fault. Now, there are several types of miscarriage, so let's break them down in a general sense. First, let's talk about a chemical pregnancy. This is a pregnancy in which the sperm does meet the egg, it implants, and it releases beta-HCG, so the pregnancy hormone. However, it doesn't go any further than this. Most chemical pregnancies occur and then complete themselves before the person even knows they're pregnant, as it happens generally before 5 weeks, which when you consider we start like day 0 or day 1 is the first day of your last period. If you ovulate 2 weeks later, then you're expecting your period at week 4 of pregnancy. You kind of have to really be looking for it to test positive and then result in a chemical pregnancy. But again, just because it's common and it happens and it's very early on does not mean that this loss is 1, not a miscarriage, and 2, not a cause for grief. Chemical pregnancies hurt. Sometimes these patients will have a positive pregnancy test one day and a negative the next day. Next, we have a threatened miscarriage, in which there is some pain or bleeding or cramping that threatens the viability of the existing pregnancy. Often the cervix is still closed, so there's no signs that it's inevitable and it's about to happen. However, the symptoms point to the fact that this pregnancy is unlikely to continue. Unlikely because not every threatened miscarriage ends in miscarriage. Then there's the inevitable miscarriage, in which there's pain or bleeding, or the cervix is open, and there is no way to stop an inevitable pregnancy loss from happening. An incomplete miscarriage is where part of the miscarriage has occurred and part of the pregnancy has been lost, and there may have been pain and bleeding and cramping, and the cervix may have opened, but there are still retained products of that pregnancy. So it's incomplete. These products do need to be removed. So we'll talk about how a little bit later as well. A missed miscarriage is where the development of the fetus just stops, and that can be from a number of reasons that we've already kind of alluded to. But the body doesn't seem to recognize this, and so you may not have pain or bleeding, your cervix remains closed, your body missed the fact that you miscarried. And finally, a completed miscarriage, as the name suggests, is when a miscarriage is completed. I want to also touch on the fact that miscarriage is not the only type of pregnancy loss there is. I'll be very brief in this section, however, I do think it's really important to highlight. First and foremost, we've got an ectopic pregnancy, in which a pregnancy occurs outside of the endometrial lining of the uterus or the womb. Commonly, this can occur in the fallopian tubes. These pregnancies can be life-threatening for the pregnant person because as they grow, if they burst, there can be a lot of bleeding internally, which is not ideal at all, and they can be devastating for the pregnant person emotionally as well. Next, we have a blighted ovum, in which sperm meets egg, it embeds, it implants, the placenta grows, but no fetus develops. So it will never be a viable pregnancy. Then we've got a partial molar pregnancy, in which there is abnormal development of the cells of the fetus from conception. These abnormal cells are not compatible with life. Interestingly, this sometimes happens when one ovum or one egg is fertilized by two sperm. Nature is weird. And then finally, we've got a molar pregnancy. So that's where the cells are abnormal from the get-go and a fetus doesn't develop at all. The placental cells that do develop can grow quite rapidly and embed in the uterus, and there is a very special kind of follow-up required for those with a partial or complete molar pregnancy, which I won't go into today, but is an interesting topic on itself. Next, let's talk about the symptoms of miscarriage, and they vary considerably depending on you, your pre-existing history, how far along you were, whether it's twins or whether it was a singleton. It's really hard for us medical professionals to tell you what to expect. Most women that I've discussed this with experience significant cramping like a really bad period, although some who have got living children can liken it to early labour and early labour contractions. And some people who have never been through a miscarriage will say that early labour feels like a bad period. So you've got some sort of baseline there. The bleeding can start off very light and be spotting. Often it's bright red. Sometimes it can be a little bit darker at the very beginning too. And that bleeding often becomes quite heavy. However, heaviness will depend on you as well. I want to quickly highlight that bleeding and cramping doesn't always mean that there is a miscarriage occurring. However, if this is occurring to you in pregnancy, I strongly suggest that you seek medical aid ASAP to establish what is actually going on. Some people during their miscarriage will also experience significant nausea and vomiting and body aches. So it's not pleasant physically at all. Once a miscarriage begins, unfortunately, there is no way medically to stop it. The way that we can manage a miscarriage will depend on you and the type of miscarriage, but generally there are 3 routes. We've got expected management, in which we as medical professionals don't do anything to encourage the miscarriage occurring, but we certainly can give you anti-nausea and anti-pain medications and emotional and psychological support, but we don't do anything to, like I say, encourage the uterus to contract or the cervix to soften or anything like that. We kind of let nature take its course. Secondly, there is medical management, in which we do all of the above, but also give you medications which, as I kind of alluded to, can help the uterus contract down and soften the cervix so that things pass through and you've got a better timeline. And finally, there is surgical management, wherein someone is put under general anaesthetic, the cervix is dilated using specific tools, and then the contents of the uterus are removed via what's known as a curettage. So if I didn't mention it, this is called a D&C, or a dilatation and curettage, or curette. And this often is done as a day case, so people don't have to stay overnight for this. Sometimes surgical management is opted to if there has been a missed miscarriage, or if a miscarriage is incomplete, or there's been a failure of medical management. But really, we have 3 options, and we will, as your healthcare team, discuss with you all of the options and then come to a conclusion as to what's best for you with you. Now, most people who experience a miscarriage will go on to experience a successful pregnancy in the future. Having one miscarriage does not increase your risk of having a subsequent one. That being said, if you've experienced 3 or more consecutive miscarriages, I strongly urge you to chat to your healthcare team because there may be an underlying medical condition that's causing this, and it's at 3 consecutive miscarriages that we begin to look into this, simply because it's so common otherwise. Miscarriages are common and horribly, horribly devastating. I am so sorry to anyone watching this who is experiencing one or has experienced one. I'm so sorry. Through this journey, I strongly urge you to reach out to friends, family, colleagues, and your healthcare team because you should never go through this alone. I wish anyone on their trying to conceive journey the best of luck and hope that you have successful pregnancies in the future. That's enough from me today. It was a bit of a more somber video, but I hope that you've learned something from it and can take something from it. If you have any questions, please let me know. Like this video, subscribe if you haven't already. Leave me a comment about what you want to see next. Until next time, guys, stay safe, stay healthy, and I'll see you in a video very soon. Bye.